we shall go on to our next speaker, Dr. Bhagwati Wadwekar, and who is from the Department of Ophthalmology, Sri Manakula Vinayagar Medical College Hospital. And the topic is going to be a rational approach to managing blind eyes. Very important talk. On to you, Dr. Bhagwati.
Yeah, I like to thank Chitra madam and Dr. Vidya for giving me this opportunity. So, blind eye is the one with the visual acuity of counting finger or the worse, and there is no probability of recovering the vision in such a patient. And these patients have already exhausted with ongoing treatment for recovering the vision. Hence, it is very important to handle these patients with care. So for the purpose of understanding, I will like to divide according to the cosmesis and the pain into the 4 categories. The first category is blind eye with no pain and normal cosmetic appearance, where the vision is the main concern. The second is blind eye with a pain and normal cosmetic appearance, where the eye pain is the concern. Blind eye with pain and abnormal cosmetic appearance, where both eye pain and cosmesis is a concern, and blind eye with no pain and abnormal cosmetic appearance, where cosmesis is mainly the concern. So this is a blind eye first category, blind eye with no pain and normal cosmetic appearance. Here you need to take a detailed history, do detailed physical examination and the relevant investigations to determine what is the cause of the blindness. Then you need to make sure that the patient gets the treatment for the condition which has led to the blindness. Explain the poor visual prognosis for the blind eye. Explain the risk of blindness in the other eye so that the patient is able to be more compliant with the treatment and give protective glasses and tell him the importance of the follow-up. This is another category where blind eye with pain and normal cosmetic appearance. So in all these eyes, you have to do a thorough clinical examination, which includes the intraocular pressure and fluorescent staining and slit lamp examination for cells flare and iris neovascularization. If the pain in the eye is due to the increased IOP, then you can go ahead with pressure lowering drops and topical steroids and cycloplegic drops. And if it is due to corneal surface problems, you can give lubricating drops, therapeutic contact lenses, topical steroids. If it is due to inflammation or like uveitis, you can give topical steroids and cycloplegic drops. If there is no improvement and if the patient is having the high IOP and if patient is willing for the intervention, then you can go for cyclodestructive procedures such as cyclophotocoagulation with diode laser. Or if patient is not willing for cyclodestructive procedure, then you can give a retrobulbar injection of ethanol 2 ml, 96%. But a better alternative is chlorpromazine, which has a longer efficacy, that is around 1 year. Will be the painless period, and also efficacy is good, that is 80 to 85%. Then you can give for exacerbations, you can give NSAIDs and gabapentinoids. If the patient has the corneal surface problems, then you can give a conjunctival, you can do a conjunctival advancement flap such as Gunderson flaps or the amniotic membrane graft. These actually work by preventing the proteolytic enzymes in the tears for coming in contact with the corneal surface and thus preventing the corneal surface. This will also make the cornea surface vascularized, and this will reduce the sensations of the cornea. So if the patient in the later stage wants some shell, we can put it over for the cosmetic purposes. If patient is not willing for this, then you can do anterior stromal puncture followed by the bandage contact lens. And for exacerbations of the pain, you can add systemic medications and retrobulbar injection. If the pain is due to inflammation such as uveitis, now the recent proposed treatment is injection triamcinolone intravitreal in the single dose of 12.5 milligrams per 0.3 ml. If patient is not willing for this, then we can give a retrobulbar injection. If none of this works, then the last resort is evisceration or enucleation. But in a clinical scenario, we should discuss evisceration and enucleation even when we are putting the patient on the medical treatment so that the patient is ready emotionally and psychologically for this procedure. Now, this is a patient with a painful blind eye due to glaucoma, end-stage glaucoma, and his IOP after the maximum IOP lowering medications was 30 millimeters of the HG. His pain was not responding to the topical treatment and the cyclodestructive procedure, and then went ahead with evisceration with implant in this patient. This is another category of blind eye, where the blind eye with pain and abnormal cosmesis, where both cosmesis as well as the pain is a concern. In such a case, you should discuss with the patient what he is concerned about, pain or cosmesis. If he wants only the pain relief, then you can go ahead with the previous treatment shown in the previous slides. And if the patient is concerned about both pain and cosmesis, then you can decide for evisceration or enucleation even at the earlier stage. Now, this is the fourth category, that is blind eye with no pain and abnormal cosmesis. Now, the abnormal cosmesis in this case can be due to corneal opacity, or it can be due to a thumbsical eye, or it can be due to a staphylomatous eye. Now, if patient have a blind eye with corneal opacity and a normal sized globe, cornea is smooth, then you can go for a cosmetic contact lens trial. If the patient tolerates well, then you can continue the cosmetic contact lens. If patient does not tolerate, you can think of doing the corneal tattooing. If the cornea surface is irregular or the anterior staphyloma is present, you can go with evisceration or enucleation with the implant. In case on B scan there is a intraocular malignancy, you can plan for enucleation with the implant. Now, this is a patient with having the anterior staphyloma. In this condition, we did evisceration with the implant. But if the anterior staphyloma is covering the most of the sclera, then you can also think about doing enucleation with implant in such cases. Now, this is a blind eye with no pain, but a thumbsical eye. So, in this, we can give a shell trial to these patients. So, if the patient tolerates these shells, then you can continue with the shell. If the patient, if it is not matching with the other eye shell, then you can send him to the ocularist to get the custom fit prosthesis. In case the patient does not tolerate these shell, then we can go ahead with enucleation with implant. Now, this is a patient who is having the thumbsical right eye. You can see the conjunctivalization of cornea there. So we gave her the shell trial and she was able to tolerate the shell and she was quite happy with the shell. And so we asked her to continue it. This is another patient who is having the right eye thumbsical. You can see the cornea is clear. So when we gave shell to this patient, he was not able to tolerate that shell. And then we did a enucleation with implant in this patient. You can see the residual ptosis here after enucleation with implant, which was corrected later with frontalis sling. The choice of the surgery, whether to do enucleation or to do evisceration, depends upon what is the ocular disease, and it also depends upon the surgeon's preference and patient's preference. So absolute indication for the enucleation is any intraocular malignancy or a badly traumatized eye where repair is not possible. So in these cases, if we do enucleation, there's no fear of sympathetic ophthalmia. Now, evisceration is a simple surgery. It is less complex and it gives a very good implant motility and less of bleeding is there. Hence, most of the oculoplastic surgeons prefers evisceration with implant in all the other cases. So, evisceration with implant can be done in staphylomatous eye or it can be done in endophthalmitis. But for panophthalmitis, there are different school of thoughts. Like first, some clinicians think that they do evisceration in case of panophthalmitis because it gives a very good implant motility and it is an easy procedure. But if you are doing evisceration in case of panophthalmitis, it is good to give the IV antibiotics and anti-inflammatory to control the infection and the inflammation before doing surgery. So this is a lady where we did evisceration with implant in panophthalmitis after giving the IV antibiotics and anti-inflammatory. The other school thinks that we should not do evisceration as it may transfer the infection from to the brain through the meninges, or there may be residual infection which may be left in the sclera. Evisceration we should also do in expulsive hemorrhage. Now, intraocular malignancy is an absolute contraindication for evisceration. We should also avoid evisceration in few cases, such as severe trauma, where the uveal tissue is going to be adherent and it is very difficult to clear the uveal tissue from the sclera, where the prior VR surgeries has been done, like cryotherapy or laser therapy has been given. So again, the clearing of the uvea is very difficult in such cases. In unknown etiology, when eyes thicicle and etiology is not known, especially in children and in the elderly people, we should avoid doing evisceration. In the severe thicical eye, we should avoid doing evisceration because we won't be able to put an optimum size prosthesis implant in such cases. Whereas in mildly thicical eyes, we can do evisceration where we can give the relaxing cuts or we can do sclerotomy for mildly thicical eyes. If there is extensive calcification, then there is a chances of having the occult tumor. So it is better to avoid evisceration in such cases. Now, we should be very clear about the patient expectations before evisceration or enucleation, whether patient wants cosmesis or whether the patient wants only the pain relief. We should go ahead with a B scan to rule out the malignancies. If UBM is available, you should do UBM also, which will help us not to miss the anterior segment tumors. And CT scan and MRI may also be helpful in thicical eyes because the B scan is maybe difficult to perform B scan in such eyes. We should send the enucleated eyeball for histopathology as well as the eviscerated contents, which we should send for histopathology. Now, these are the different implant. This is non-integrated implant, that is silicone and PMMA. This is semi-integrated implant, and this one is integrated implant, hydroxyapatite and porous polyethylene. So this is integrated to the orbital tissues by the growth of the fibrovascular tissues. And this can also be integrated with the prosthesis with the help of pegging. This one is a dermis fat graft, which is a biointegrated implant. So which implant we should put? So in most of the cases, the implant of choice is PMMA or silicone, particularly if we are doing enucleation. In case of a child, so we should use PMMA or silicone, and also in the adult where there is intraocular malignancy, we should do the PMMA or the silicone implant in such cases, because these patients may require radiotherapy later if there is any recurrence. And these implants, they are resistant to the radiotherapy. And it is easy to identify the recurrence with these implants, that is PMMA and silicone.
1 minute left.
These implants can be exchanged because these are not integrated with the orbital tissues. These are also very much cost effective. So in evisceration, we are going to put it in the scleral shell, whereas in after enucleation, we are putting it in the intraconal space. Now, if you are putting a smaller implant, there may be a superior sulcus defect like this, and the prosthetic motility may not be very good. If you use a larger implant, there are the chances of implant extrusion or erosion, and you may not be able to put a prosthesis in the front. So hence, we need to put an optimum size implant. So our globe is 7 cc, and we need, when we do a enucleation, there may be deficit of this 7 cc. So we have to compensate for this 7 cc, which is done by 60 to 70% by the implant and 30 to 40% by the prosthesis. So this 4.5 cc corresponds to 20 millimeter of the implant. And 20 millimeter of implant is actually the ideal size for the adult. And if we are wrapping it with a sclera, then you need to subtract the 2 millimeters. That is, you can put a 18 millimeter implant and wrap it with the sclera. That makes total of the 20 millimeter. If you are doing evisceration, then we have to use a small size implant, because for evisceration, we are putting it in the scleral shell, whereas in enucleation, we are putting it in the posterior Tenon's space. So for evisceration, 16 millimeter implant is ideal and also safer, because we can suture the sclera without tension. And this will also provide us some space to keep the prosthesis in the front. So these are the few surgical tips for enucleation. That is, do peritomy very close to the limbus so that most of the conjunctiva is saved. Avoid buttonholing, use blunt scissors. And when you are putting a tagging suture, silk suture, then keep at least 1 millimeter distance from the insertion and pass another suture, vicryl suture around 6 millimeter away from the first suture and cut between the two muscles and leave some stump on the either side so that the suture does not slips away. And then prolapse the eyeball out of the eye speculum so that the optic nerve is stretched, and that will help us to get a long stump of the optic nerve while cutting. Try to take a long stump of the optic nerve without causing damage to the vessels there and the nerves coming through the superior orbital fissure so that the good implant motility is maintained after the procedure. And put the conformer in the end. For evisceration, the few surgical tips: do a peritomy, try to save the conjunctiva. And when you remove the uveal tissue, try to take in a single bolus, try to avoid taking in the fragments. And in the end, you can apply the absolute alcohol to destroy the whatever small fragments are left, and always send the tissue for the histopathology. Thank you very much.
Thank you, Dr. Bhagwati. That was such a thorough, detailed talk. Vidya, can you just take one question before we go on to our next speaker?
Yes, Bhagwati, that was an excellent presentation, and you did mention everything. Actually, you said it all. But I just have one question. How you mentioned about doing evisceration in a mildly thysical eyes. So how do you do that? What is your technique of relaxing incisions? How do you do that exactly?
Actually, there are multiple techniques described in the literature. So one of the simple technique is just to give the 4 relaxing incision in between the rectus muscle. You can give oblique incisions between the rectus muscles, and if you want, this will expand the globe equatorially, and you will be able to put a larger implant. And you can also give a relaxing incision in a circumferential fashion around the optic nerve. And other technique, recent technique described is a 4-petal technique, which you can cut the 4 petal likes from the sclera, avoiding the rectus muscles, and then suture those 4 petals. And this will this will help you to accommodate a larger implant.
Excellent. Okay. Right.
Thank you.
Thank you.